Good morning, everyone. Good morning, good morning.
Good morning.
We are going to get started, and there are seats available. So I welcome you all to come in the back. Molly, you can come on in. Because there really are seats available down in the front. And I welcome you to come and sit. Yes, Ishamini, yay, you're here. You can come on in towards the front. And I'm so happy with the turnout. Okay, because we have so much to cover in a short amount of time, I'm going to go ahead with our introduction, but I want to start off by saying Happy Black History Month. I am so excited to really, yay, to really end this wonderful month of celebration with Dr. Kamara Phyllis-Jones as our speaker, really talking about how we can really practically achieve health equity by really confronting racism. So we are just at a very special place and a very special time. So I welcome you all. I welcome you to really be a part of this experience. I am going to, of course, introduce Dr. Jones, but I also will need your help because in the spirit of Black history and really African tradition, I want to acknowledge some really key Black pioneers within the field of mental health and just give really presence and honor to their legacy and their work. I think because of the path that they set before us, I exist to be in a place before you, to be able to do my work, to speak. And similarly, Dr. Jones, truly as a pioneer and a trailblazer, talking about social justice and racism before it was in vogue, before it was chic, before there was even a name to it, these pioneers were able to do this work. So when I say their names, I'd like you to say Ashe, in the really Yoruba tradition of I hear you, I see you, and the Black church will say amen, but really wanting to respect different religious beliefs, we can say Ashe just as a way to honor these people. And then we'll get into our guests. So I'd like to start off with Dr. Solomon Carter Fuller. He was the first Black psychiatrist in this country. Was also a pioneer in Alzheimer's research. He could not do his research in the United States and had to go to Germany and actually did a lot of work showing that there were structural changes in the brain as a result of the disease, and he is often not credited for his work and really characterizing the disease. So today we honor Solomon Carter Fuller. Amen, y'all, yes. So next is Jean Spurlock, who is, was a Black female psychiatrist, really professor, author, advocate. She was really formidable in making sure that there was a space to discuss and to have literature and academia about the effects of mental illnesses for Black children and adolescents. And as a result of all her work and advocacy really in Washington, she has 4 fellowships in her name, 2 through the American Academy of Child and Adolescent Psychiatrists, and then 2 through the American Psychiatric Association. So today we honor Jean Spurlock for all her work. Next is Chester Pierce. Again, he is just amazing. He was actually one of the co-founders of the Black Psychiatrists of America, which I'm a member of, and I implore every psychiatrist, Black or white or otherwise, should be a member of the Black Psychiatrists of America. We really learn about the way psychiatrists is practiced throughout the world and affects people of color. Chester Pierce really founded this organization back in 1965 when the American Psychiatric Association refused to acknowledge the issues that were really relevant to Black patients, but also Black physicians. So to him, we are thankful. Also, he coined the term microaggressions, and he is often not given that credit. So to him, we honor him, Chester Pierce. 2 more. Altha Stewart. She is the first Black president of the American Psychiatric Association. The organization is the largest organization for mental health providers with over 38,500 members to date, and was founded in 1844. This year in San Francisco, we celebrate the 175th anniversary of this organization, but not until last year did we have a black president. So I really want to acknowledge her tremendous efforts and the way that she has really led this organization and being very deliberate to discuss issues that affect women and also people of color. She is a good friend and mentor, so for her, I want to honor her legacy. And then finally, really wanting to end with our very own James Comer, who is a full professor here at Yale at the Child Study Center, is still trucking along at 84 years old, still in his right mind. I had the chance to sit down with him and really thank him for all of the work that he has done. He is really, I think, well known. Well, he was also a co-founder of the Black Psychiatrists of America as well, and is known nationally and internationally for the creation of the Comer Development Program that was able to achieve great success for all children, but especially children of color. And so I am so grateful for his pioneering work, and we say, thank you. So we are just in a place where African Americans have really been amazing and exemplary in their work in advancing mental health research and clinical practice. And I really just wanted to take the time to thank our ancestors for their work, for setting the stage for this amazing opportunity we have today. I'll be very brief because I'm taking away from Dr. Jones's time. This woman is super special to me, and I have a slide because I have to show how excited I am. I'm a fan. And when I saw her at the Student National Medical Association a few years ago, I said, I love you. And you don't even know me, but you have your writings and your presentations have really filled me over the years, and I'm so grateful for everything that you have done. And she just gave me the biggest hug, and she said, you are wonderful, and you are excellent, and you will do well. So, Ashe, thank you for that. Okay, so Dr. Jones, MD, MPH, PhD, all of the titles, is a senior fellow at the Satcher Health Leadership Institute and the Cardiovascular Research Institute at Morehouse School of Medicine, a historically black college and university. She's also past president of the American Public Health Association. Dr. Jones, by training, is a family physician and epidemiologist whose work really focuses on naming, measuring, and addressing the impacts of racism on health and the well-being of the nation. She seeks to really broaden the national health debate to include not only universal access to high-quality health care, but also really bring attention to what we call the social determinants of health, not forgetting poverty, but also the social determinants of equity, right, which includes racism. So indeed, her allegories on race and racism illuminate topics that are otherwise difficult for many Americans to understand or discuss. So she aims to really use her work to catalyze a national campaign against racism, and she's able to do this in a very kind of nuanced and exceptional way. And I think we are extremely privileged to have her here in our presence to really engage in her work. And I will turn it over to her. One thing I will say, housekeeping, and Dr. Jones, you can come on up, is that she asked that you actually ask questions throughout her presentation. We will go all the way to 11:30, so feel free to ask questions, and I'll let you kind of take ownership of whose questions you'll answer. But I will say at 11:45, she has to go because she has a very tight time schedule, and I want her to have lunch with some of the trainees. So at 11:45, she's going to be ushered away. So make sure you ask your questions. Okay, Dr. Jones.
Wow, there's a room full. There are actually seats in the aisles, as some of you see, and also seats down. If there's a seat, if you can all move to the middle, if you see that there's a middle-ish seat, available, but they seem to be all full. But come on down.
Yeah.
Come on down, really.
There's 2 seats down here.
These are slightly obstructed, but it's better than nothing. And here's a chair. And I don't see any others, but oh, here, 2 right here. Come on down. 2 seats here. There are 2 seats here. So. And I'm excited to be here. I'm not going to turn on the, have also this lavalier mic, but I'm going to stand here. I'm not going to move because every time I turn the lav on, then there's feedback. So we're just good there. I want us to engage in a conversation, and we're just the right size and just the right energy to do this. But at some point, I might need to rein us in. So because at some points, I might say, okay, does anybody have anything to add to this image that I've just presented to help us understand levels of health intervention? Or is there somebody who feels challenged, perhaps, by a definition I just gave, or wants to give me an amen because they're like, oh, Dr. Jones, you're speaking my life. I want to engage all of that. So at any point during my remarks, if you have something to add, wave your hand wildly. I will finish my sentence, and then I will address it. And then, depending on how the timing goes, I may or may not open it for longer or shorter periods of time, because I do have several allegories on race and racism, kind of teaching images based on my own real life that are instructive for us to understand these very important realities. I have some definitions and the like. So let me get started. I'm going to start with a story based on my experience when I was a medical student. And it was one Saturday, actually, and I was with some friends in my apartment, and we were studying long and hard. And it got late, and we got hungry, and I had no food in the apartment. So that was typical. So anyway, my friends understood, so they said, okay, well, let's go into town. So we went into town to find a restaurant. And we find a restaurant, and we walk in, and we sit down, and the menus are presented. And we order our food, and the food is served, and here we are eating. Hallelujah. But that's not a very instructive story, especially because I want this story to be instructive about racism. So hold on. Most of us have had this experience. But as I sat there eating with my friends, I looked across the room, and I noticed a sign. And that sign was a startling revelation to me about racism. So now you're intrigued. Dr. Jones, what did the sign say? Well, the sign said open. So now I know I've lost most of you. So let me recap. Here we are, sitting in a restaurant eating. I look across the room. I see a sign that says open. If I hadn't thought anything more about it, I would have assumed that other hungry people could walk in, sit down, order their food, and eat. But because I knew something about the two-sided nature of those signs, I recognized that now, because of the hour, the restaurant was indeed closed. And that other hungry people just a few feet away from me, but on the other side of the sign, would not be able to come and sit down, order their food, and eat. And that's when I understood how racism structures open, closed signs in our society. That racism structures, if you will, a dual reality. And for those who are inside the restaurant, sitting at the table of opportunity eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on, because it's difficult for any of us to recognize a system of inequity that privileges us. It is difficult for men to recognize male privilege and sexism. It is difficult for white Americans to recognize white privilege and racism. It is difficult for all Americans to recognize our American privilege in the global context. Except we got a little taste of that with Ebola, did we not? And we get a taste of it anytime you travel outside of this country, you get a taste of that privilege. You understand it more. But those on the outside are very well aware that there's a two-sided sign going on, because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing. It doesn't even compel you to act, but it does equip you to act, so that if you care about those on the other side of the sign, which is an if, but if you do, you could even talk to the restaurant owner who is, after all, inside with you. And you could say, restaurant owner, there are hungry people outside. Why don't you open the restaurant again? Let them come in. You will make more money, and oh, the conversations we could have. Or maybe what you'll do is pass food through the door. Or maybe you'll try to break that glass or tear down the sign, but at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat. Because you'll understand something about the two-sided nature of that sign. So we could pause right here, but I'm not, unless somebody has something that they really want to add here. But I will say that I often ask the question, how could people who are born inside the restaurant know something about the two-sided nature of that sign? Because there are many, many ways, and maybe we'll take that up in some later discussion. I once had a 3-hour conversation in Flint, Michigan with a community group just asking that one question. We never got to the rest of anything else I wanted to talk about. So that's why I'm not going to open it up right now, but maybe we can come back, right? I haven't defined racism yet, and I'm aware of that, and different people have different ideas, but I want to share one more image with you before I define racism and talk about how it can directly impact health. This intervening bit is explanation of why am I here at the Yale School of Medicine doing psychiatry grand rounds and talking about racism. So this is to frame different levels of health intervention for us to understand that talking about and addressing racism is a core part of our medical endeavor. So here we go. Whoops! Boom. Somebody just fell off of the cliff of good health. And if that were you or somebody in your family, you would be delighted to find an ambulance there at the bottom of the cliff to speed you on to care, right? But if we were concerned about other people who might come along that cliff face, so if we were concerned about population health, public health, community health, we might well ask ourselves, what could we put in place as a health intervention besides just stationing lots of ambulances at the bottom of the cliff? So somebody's going to say, I know, let's put a net halfway down. That way, even if people fall, we can catch them before they get crunched up at the bottom. So that is an excellent idea. Although the more you think about it, nets do have holes in them, so some people might fall through the cracks, right? But never mind that, we could actually make that a trampoline halfway down, no holes in a trampoline. But even if we had a trampoline halfway down that cliff, we might well find ourselves with lots of people just bouncing up and down and at half functionality, not able to get back to the top of the cliff. So what else could we put in place as a health intervention? Well, clearly we need to think about a fence at the edge of the cliff to keep people from falling in the first place. But even that fence has to be a very, very strong fence if there's a lot of population pressure against it. So what else could we do as a health intervention? Well, we could move the population away from the edge of the cliff. So let me label these interventions that I have depicted so far, where the ambulance at the bottom of the cliff represents acute medical care and what we on the public health side of things describe as tertiary prevention, which is, we talk about these 3 levels of prevention: primary, secondary, tertiary. Tertiary prevention is preventing complications from disease that's already manifest. So it might be preventing suicide from depression, or it might be preventing amputation from diabetes, that kind of thing. That's the ambulance. The net, or trampoline, halfway down, these are our safety net programs, which are often in our social services, as well as secondary prevention, which is about early detection, screening. The fence represents primary prevention, keeping bad things from happening in the first place, and moving the population away from the edge of the cliff is what we describe as addressing the social determinants of health, which are those determinants of health that are outside of the individual, beyond our individual genes and beyond our individual behaviors. These are the context of our lives, including individual contexts like education, occupation, income, wealth. So addressing poverty is a way of addressing the social determinants of health, moving the population away from the edge of the cliff. They include neighborhood context. Can you even get fresh fruits and vegetables? Can you walk safely? Is there a job in your neighborhood, even if there's not one right there? Is there access to a job? What's the quality of the schools? On and on. So addressing adverse neighborhood conditions is a way of addressing the social determinants of health. So this is a useful schematic where we could talk within your realm of behavioral health, right? psychiatry, mental health, substance use disorders. What would that ambulance be? What would the net fentanyl? So you guys can chime in here with me now, but here's just my very quick thinking. So the ambulance might be, it might be hospital care for, an acute psychotic break, or it might be substance use, hospitalization and detox, okay? The net, or trampoline halfway down, might be screening. So maybe it's a PHQ-9. In your practice, it's a screening for mood disorders or psychotic disorders, or for substance use disorders, either in a mental health setting, or even if we get really integration between behavioral health and primary care, in a primary care setting, with that kind of screening thing. The fence is sort of interesting because that's preventing individuals from falling off one at a time. So in the substance use world, maybe it's alcohol prevention trainings in junior high or something like that. Or I would say in the policy world, and now I'm not going there because I recognize there might be like big pros and cons on every side, but the whole thing about the legalization of marijuana. I know there are many pros, many cons, and all of that. But that might be a policy type of thing. It depends on where you are, right? Moving the population away from the edge of the cliff, addressing the social determinants of health. That's, I don't have to think psychiatry versus, diabetes versus cardiac disease. For everybody, it's about excellent educational opportunities. It's about excellent employment opportunities, same level of employment. So for moving the population away from the edge of the cliff is about addressing these adverse context and the differences in context. So it's a nice diagram. You could go into a community meeting this afternoon and you could ask the question, how should we be spending our health resources, even our mental health, behavioral health, psychiatric health resources? How much in ambulances versus nets versus fences versus moving the population? But as useful as this diagram might be for starting those kinds of conversations, as I have presented it so far, it has a huge fatal flaw. And the huge fatal flaw is that it does not yet equip us to talk about how health disparities arise. So now I want you to keep this cliff in the back of your mind. We're going to shift gears for just a moment to talk about how health disparities arise on 3 levels, and then we'll come back to the cliff. So especially when you're talking about racial ethnic health disparities, there are many axes on which health disparities arise. There's social class and geographic and all. But especially in the racial ethnic side, which has a very long history in our nation and very kind of entrenched, it seems, we have strong evidence about differences in the quality of care received within the healthcare system. When the Institute of Medicine in 2002 released its unequal treatment report, pulling together what were then hundreds of studies documenting differences, for example, in how vigorously your chest pain might be investigated or treated, depending on your race, even if you're in the same hospital system, everybody covered by the same insurance, right? Or pulling together studies that were documenting differences in how much pain medication you might get if you walked into an emergency department with a long bone fracture, depending on your ethnicity or race. That sent shockwaves through medical care. Some of you guys are too young to even have experienced that. But that IOM panel, now the National Academy of Medicine, they recognize that's not all the end-all and be-all of how health disparities arise, especially racial ethnic health disparities, because some people can't even access a care system in the first place. That's a second level at which health disparities arise, differences in access to care. But then I'm hoping that everybody in this room recognizes that health is not really created within the health sector. So a third level at which health disparities arise are differences in the conditions of our lives. Differences in our life opportunities, exposures, and stresses which are making some individuals and communities sicker than others in the first place. And if you wanted to depict the relative influence of these different levels at which health disparities arise, you could actually draw a pyramid, or better yet, really understand it as an iceberg, where the huge hidden base are the differences in the conditions of our lives. And then the very same people who have been made sicker are sometimes frustrated because of limited access to the healthcare system. And then even the lucky ones who get into a system are sometimes further injured because of differences in quality of care. So now, remembering those 3 levels at which health disparities arise, we are going to go back to our cliff. But now we're going to recognize that we're really not dealing with a flat two-dimensional cliff, but actually we are dealing with a three-dimensional cliff. And at some parts of the cliff, there's an ambulance there, but maybe that ambulance has a flat tire. So it's slow or goes off in the wrong direction. Or maybe there's no ambulance there at all, and maybe there's no net nor fence. And usually at those parts of the cliff, the population is being pushed closer to the edge. So now, let me label these observations about the three-dimensional cliff with how health disparities arise. Where the differences in quality of care are represented when there's an ambulance there, but it slower goes off in the wrong direction. Differences in access to care are no ambulance, no net, no fence, and differences in underlying exposures and opportunities are represented by the closer proximity of that greenie population to the edge. So now that we recognize that we're really dealing with a three-dimensional cliff, there's a whole new set of questions that arise. Let me first say the first question is, how did the cliff become three-dimensional in the first place? And that's usually because of historical injustices that are perpetuated by present-day contemporary structural factors. But given that the cliff is three-dimensional, we need to ask, why are there differences in how resources are distributed along this cliff face? And why are there differences in who's found at different parts of the cliff? Why are the oranges back here in a way and the greenies being pushed closer to the edge? And when you start asking and addressing those questions, you're now doing something that differs from addressing the social determinants of health, which I described as moving the population away from the edge of the cliff, addressing poverty, adverse neighborhood conditions, and the like. When you start talking about systems of power that can differentially distribute populations and resources, you're now talking about the social determinants of equity, which include racism, sexism, heterosexism, economic systems like capitalism, and the like. So that on this cliff, I have, if you will, distilled three different dimensions of health intervention, where one dimension is a line, 2 dimensions is a flat plane, 3 dimensions is space. Well, along the line at the edge of the cliff is where we can have all of our curative and preventive health services right there. The Affordable Care Act is an edge of the cliff conversation, getting to universal access to high quality health care. Some are framing that as Medicare for all. That's still an edge of the cliff conversation. And as important as it is for us as a nation to join the rest of the world, basically, in having universal access to high quality health care, and the reason it's important is that's how a civilized society values all of its people equally, right? But as important as that is, that's still an edge of the cliff conversation. And you can overwhelm any system, no matter how wonderful it is, if everybody's pushed against the edge. So we must move into that second dimension. We need to be moving the population away from the edge of the cliff, addressing poverty, adverse neighborhood conditions, and the like, addressing social determinants of health, if we want to have large and sustained improvements in health outcomes. But the trick there is if we're about moving the population away from the edge of the cliff without recognizing that we're really dealing with a three-dimensional cliff, we are at risk of moving some of the population, but not all of the population, and actually making health disparities worse. So we need to acknowledge and address the three-dimensionality of the cliff. We need to address these social determinants of equity or inequity, including racism, sexism, heterosexism, capitalism, and the like, if we want to achieve social justice and eliminate health disparities. Now, actually, this is about the time where I would open it up for people's comments, but I already can feel, okay, so I'll address the first 2 comments or questions that come up. And I'll actually wait until at least one comes up. And while I'm waiting, why don't the people who are in the back come sit down in the aisles or come move in, because you guys are so far back, I don't even know if you can hear me back there. Can you? There's a chair. There's an empty chair right up here. There are, if you don't mind, if you have pants on and don't mind sitting in the aisle. But there's an empty chair right up here on the far edge on this side. So, anybody with a question or comment? Was it useful? Did you understand it? Okay, so we'll just go there. Yes? No? No. Okay. Oh, I scared you guys. Oh, my God. Okay. No questions. Thank you. So, well, let me share with you some questions that have come up in the past. One question that I often get is, Dr. Jones, if this is a useful depiction of possible levels of health intervention, and if we as a nation or as a people agree that an ounce of prevention is worth a pound of cure, why are we spending so much money on ambulances at the bottom of the cliff? And I have like 3 levels of answer to that. The first is that there's a lot of money being made down there on ambulances at the bottom of the cliff by health systems, by healthcare providers, by pharmaceutical companies, by medical device companies. There's a lot invested there. And there's a lot invested there because, so this is a second kind of tiny answer, we are more tuned to addressing the urgent than addressing the important. So when somebody falls off the edge of the cliff, then we address that urgent as opposed to like stepping out a little bit. But the base reason for this, in my mind, is that we as a nation are so narrowly focused on the individual that we don't even recognize there's been a health problem until somebody's fallen off the edge of the cliff. So we don't recognize the closer proximity of one population or any proximity of any population to the edge as a health problem. We don't even use aggregate measures of health, kind of community level measures, maybe even income inequality or social cohesion or any kind of aggregate measures as measures of health. And so we're just busy collecting people at the bottom of the cliff or in our nets, in our very heavily laden, about to break nets, as our response. And well, I do have to say this. I recognize the importance of ambulances at the bottom of the cliff. We all need them there. But even if that's your day job, and many of the people in this room are working either as an ambulance or a net, I recognize the room where we are right here. And we need strong of that. But if your day job is just scooping bodies up and, sending them on for care, if you're trying to be or train the best ambulance drivers that there are, right? We need that, but even then you need to wonder, is there a net above me, and how strong is that net? Is there a fence at the edge of the cliff? How strong is the fence? How close is the population to the edge? At what part of the cliff am I operating today? And do I act differently when I'm at different parts of the cliff? Come on now. But furthermore, wherever your day job is, I would say that as a citizen, we all need to be concerned about the whole. That is what citizenship, I'm not talking about national citizenship, I'm talking about human citizenship. And concern about the whole has to start with concern about the three-dimensionality of the cliff. So here's another question that I'm sometimes asked. Why are the greenies launching themselves over the edge of the cliff? Right? So people ask that sometimes, why are they eating so much fried chicken? Or why are they doing this? Or why aren't they doing that? And it's a lot of the behavioral stuff, right? So that also, I would say, reflects our narrow focus on the individual, because when you're narrowly focused on the individual, that makes the systems and structures that are pushing the greenie population closer to the edge invisible or irrelevant. But it also reflects a second, so I actually have now elaborated 5 barriers to achieving health equity. The first is our narrow focus on the individual. The second is that we as a nation are ahistorical, and we act as if the present were disconnected from the past, and as if the current distribution of advantage and disadvantage were just a happenstance. And so our question, why are the greenies launching themselves over the edge of the cliff, is a very strong outcome of that lack of historical understanding. That is why I was happy when you started us off today understanding some history. We should start all of our proceedings understanding something about history. It would be actually good if the Department of Psychiatry modeled for all of the Yale Medical School and for all of that, to not only to do that, just what is the history of New Haven? What is the history of Yale University? What is the history of the Yale School of Medicine? What is the history of, and really dig deep to understand. So I was very appreciative. I didn't even know you were going to do that, Dr. Jordan, and that was right on. Okay, but here, let me see. I just use up all my time, and nobody's even asked me a question. Okay, so here's a third question, though, and people do not ask this one out loud, but we all act this often in our daily lives. The question is, this situation looks fine to me. What's the problem with the three-dimensional cliff? Now, the way that we act this out loud is we might leave our beautiful homes in our beautiful neighborhoods, drive through a distressed, underinvested, oppressed neighborhood, get to our safe work settings, and not feel a strong sense of urgency to do something about that distressed, underinvested neighborhood that we just drove through, or that we might actually be practicing in, right? And that reflects a third huge barrier to achieving health equity, which is our endorsement of the myth of meritocracy. Our endorsement of the story that goes something like this: if you work hard, you will make it, right? I give you that most people who have made it have worked hard, right? Everybody in this room has worked hard. Although I have to say, in the world, or even in the nation, or even our leadership, not everybody who has made it has worked hard. But but so yes, most people who have made it have worked hard. But there are many, many, many other people working just as hard or harder who will never make it because of an uneven playing field, where that uneven playing field has been structured by racism, sexism, heterosexism, all these systems of structured inequity. And when we do not acknowledge the existence and pertinence of those systems of structured inequity, then we are endorsing that myth of meritocracy. I will hopefully give myself some more time at the end to come back to that circle. So, all of that was to say that addressing racism as one of these systems of structured inequity has to be core to our health endeavor, right? We cannot be blind to the three-dimensionality of the cliff and the importance of that. So now, finally, I'm going to define racism. And again, I'm going to invite people, just come in, please, please. Come in and sit down. I mean, sit up here, I don't mind. Really, because it makes me feel like you guys are so far away. No, honestly, sit on these stairs. These stairs are bad, you can't see from here. But sit up here, right? Come on in. Anyway, so now, what is racism? When I say the word racism, I'm clear, first of all, that I'm talking about a system. I am not talking about an individual character flaw. I'm not talking about a personal moral failing. I'm not even talking about a psychiatric illness, as I know some of my esteemed colleagues have suggested, although racism can manifest as psychiatric illness, but the essence of racism is not any of those individual level things. It is a system of power. A system of doing what? It's a system of both structuring opportunity and of assigning value. On what basis is the opportunity structured? On what basis is the value assigned? It's based on so-called race, based on the social interpretation of how one looks, which is what we call race in this country. And so, you know, take me for example, here in New Haven, you look at me, I'm clearly black. That's true in Atlanta too, true in most parts of the United States. But let me tell you this, I have experienced that in some parts of Brazil, you look at me and I'm just as clearly white. I have experienced that in South Africa, you look at me and I'm just as clearly colored. Here I am in just those three settings, basically. Same physical appearance, but the social interpretation of my appearance assigns me to three different racial groups in those settings. And furthermore, if I were to stay in any of those settings long enough, then my health outcome would probably take on that of the group to which I've been assigned, even though I'd have the same genes in all of those places. It is true for every single person sitting in this room today that there's some other place on earth where your so-called race is different from how you are experiencing it and living it here today. So we need to understand, I know that everybody in this room understands race is not biology, but we have to understand not only what it's not, but what it is. It's the social interpretation of how one looks in a race-conscious society. So that's what race is. Racism is the system that operates on that so-called race to structure opportunity and to assign value. What are the impacts of this system? Well, when we do talk about racism at all, which is not frequently enough, but when we do, we understand that racism is unfairly disadvantaging some individuals and communities. But every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. That's the whole issue of unearned white privilege that we hardly ever talk about in this country because it makes some people, especially some white people, uncomfortable. And in a room as big as this, I know that I may have just made somebody's skin do a little something right there, even though you're trying to be with me. I mean, you came to here, right? And I acknowledge that. And I used to say to people, shake it off if you feel uncomfortable. But now what I say to people is, don't shake it off, lean in. Because I have recognized that for all of us, the edge of our comfort is our growing edge, right? But even when we recognize, okay, Dr. Jones, I'm with you, we have the unfair disadvantage and the reciprocal unfair advantage, there's a third impact of racism that many of us do not recognize, and that's how it is sapping the strength of our whole society through the waste of human resources. So when we as a nation, you know, our leaders or whatever are wearing blinders, these blinders of racism that make them think that there is no genius in the barrios or the ghettos or on the reservation, so we are not vigorously investing in the full excellent public education of all of our children, because of these blinders, that saps the strength of all of us because, of course, there's genius in all of our communities. And if we were to only vigorously invest in that genius, we could be doing so much better as a nation or even as a world. You know, sometimes I say we might already be up on Mars farming. But then I say we don't even have to go to Mars. If we were to capture all that genius, we would be solving the problems in our communities today. Right? These same blinders of racism that don't value all of us equally have made us as a nation complacent with what I describe as a wholesale warehousing disproportionately of so many black and brown men in our prison system, as if that didn't separate us from human potential. And if you know folks who are either stuck in the system or cycling in and out, and I could go on and on there, I'm not, but you know that there are many geniuses caught up in this horrible vortex that if there had only been some other way, could be contributing quite productively to our society. I could go on and on with examples of how racism is sapping the strength of all of us. What I need to say is right now, this, of the three impacts of racism that I have presented, this, I think, is the most important one for us to lift up right now. We need more media stories about this. We need more data collection about this. We need more conversations around our dinner table so that more people will be filled with a sense of urgency to dismantle the system and put in its place a system in which all people can know and develop to their full potentials. Before I leave this slide, one more comment I want to make. I have experienced in my professional life, so I was at CDC for 14 and a half years. First 10 years, great. We did a lot of great work. Ask me about that later. Towards the last part, I had moved to a different part of CDC. And it came to a point where there was somebody above me who had to clear my presentations, who objected to me having that second point on there about unfairly advantages individuals and communities, and actually insisted that I take that off of my slide. And then in the tussle, right, the compromise for the time being until I actually left CDC and went to Morehouse School of Medicine, but the compromise was to take the words unfairly off of the slides. As long as I didn't characterize either one as unfair, I could talk about disadvantage and advantage. What that taught me was a very important lesson, that there are many people in this country who think that there's disadvantaged as a state, and then there's normal. Disadvantaged and normal. And the reason that people think there's disadvantage and normal is that we as a nation are ahistorical. And people do not understand that their so-called normal is built up on a whole mountain of unfair advantage. So now I'm going to shift gears again. Yes, question.
Can we go back to?
Yes.
So living in a world who loves to believe itself as being excellent, how do you get people to actually really look at that unfair advantage without them completely losing the sense of who they are and what they have accomplished? Because in my mind, a lot of people who don't want to tackle the fact that they have unfair advantages,
Right.
because it is so tied to their whole sense of who they are.
I understand.
And what they have accomplished in this world.
I understand that if it wasn't for their sole effort, then they would feel that they, I hope that's not my phone, no. No, so the question,
Part of
excellence,
this center of excellence because
of what they did as individuals. And this can affect people in all different groups. So to recap, the question is, in this place that is a place of excellence and where people are proud to be here and of their excellence, when you start talking about unfair advantage, how can you talk about that without people crumbling, basically, is the question. Well, I think that history is a good thing of it. Personal histories, the histories of other people. Often people do not compare themselves to people who have had less advantage. You know, even on that little cliff, the oranges are not even looking back to see where the greenies are on the cliff. They're just comparing themselves to the other oranges or maybe the reddies who are farther away from the cliff, right? So this is one thing that people really do not understand their relative position because they're always comparing themselves to people who have more and not people who have less. So one thing is history, to find out how they got to be where they are, personal history, family history, community history. The second thing is to really expose yourself to the breadth of humanity, to understand that not everybody had that access to that private school education, or not everybody had access to parents who could buy a house in that good school thing, because now one of the structural problems we have here is that education in most parts is still so closely tied to local property taxes, right? This is a structural problem if you have poor neighborhoods, you have poorly funded schools, which often result in poor educational outcomes and another generation lost. But to get to your question, so people need to look around at the full reality. They need to be concerned about the whole and to recognize and to be grateful, to not feel that, oh my God, if I have to acknowledge the advantage, then I am nothing. But to acknowledge the advantage, to say, I used that well, and I am going to make sure to spread that advantage in all of the ways that I can. Because if you're caught up in the myth of meritocracy, which would then deny the advantage, right, that I worked hard, therefore I made it, then you will never be able to help people who haven't made it because they didn't make it because they're lazy or stupid. But at the moment that you recognize that there's a system of advantage and disadvantage operating, and if you care about the whole, which I'm encouraging all of us to do, then you say, I understand how I was advantaged. Let me see if I can replicate these conditions for other people who right now are disadvantaged, or whatever. So it's knowledge that doesn't have to destroy one. It's knowledge that can equip one. Yes. Oh, time. Is it 30 minutes already? Oh, my God. Oh. Okay. Okay, so how could racism turn into health outcomes? How could it turn into differences in prevalence of substance use disorders? How could it turn into differences in obesity prevalence? How can it turn into differences in the numbers of our babies dying before their first birthday? How could racism turn into differences in asthma prevalence, cancer, how could it turn into health? I find it useful when trying to answer that question to think about racism on 3 levels, which I describe as institutionalized or structural, personally mediated, and internalized. So let me briefly define each of these levels, give you some examples of how they can impact health, and then illustrate them with my Gardner's tail allegory. Institutionalized racism is the system. It's the constellation of structures, policies, practices, norms, and values which taken together result in differential access to the goods, services, and opportunities of society by race. This is the kind of racism that doesn't require an identifiable perpetrator. In fact, is this thing dinging because the battery's gonna go low soon? Does anybody know why we keep getting these tones up here? Because I would hate for that to happen. You know, do you hear it too? Yeah. And it's telling me something. I always try to listen to the signals, you know.
All right. You're plugged in.
I'm plugged in and I'm muted. Okay. So, no, you know, I mean, I'm not trying to go through glibly. I got this, right? I'm trying to listen and learn, right? Okay. So, anyway, so this is the kind of racism that doesn't require an identifiable perpetrator because it's been institutionalized in our customs, laws, background, norms. This is the kind of racism that shows up as inherited disadvantage or as reciprocal inherited advantage. We see it in terms of material conditions, in terms of access to power, so differential access to quality housing by race, differential access to excellent educational opportunities by race, differential access to excellent employment opportunities, same level of income at the same level of employment. Clearly, these things impact health. Differential access to medical facilities, including linguistic access, differential access to a clean environment, and the whole disproportionate placement of toxic dump sites, or bus transfer stations in communities of color. Differential access to power as information, health information or information about our own histories. Resources, capital resources as well as social networking resources, voice in government, in media, and the like. Now, I must pick up on a strand that I'm often interrupted about now, and that's when people say, look at that first set of examples that you provide, housing, education, employment, income. Dr. Jones, isn't that how we describe social class? Why do you have that on a slide about racism? Are you talking about racism, or are you really, really talking about social class? That is a very important question. My answer starts with the observation that it doesn't just so happen that people of color in this country are overrepresented in poverty while white people in this country are overrepresented in wealth. That is not just a happenstance. And for each marginalized or stigmatized or oppressed group of color, there's been some initial historical injustice. So for American Indians, that initial historical injustice was the taking of the land. And the near genocide, and then moving the survivors to reserve lands, reservations. And then in some instances, something good was found under one reservation. Oops, you got to pick the people up and move them somewhere else. We could talk about Mexicans who have lived for centuries in Mexico, never crossed the border, but the border crossed them, and now they're in New Mexico and Arizona and the like, and their grandchildren and great-grandchildren are still being stigmatized and harassed, right? We have a very curious labor, relationship with labor, like immigrant or migrant labor. So when we imported Chinese people over here to build our railroads, they were unable by law to marry and unable by law to bring their families. Now we have so much of a reliance on immigrant labor to pick our fruits. In Georgia, there's people are crazy. Who's going to pick the peaches, with all of this attack on migrant labor? You could talk about, so let's go to World War II, where we interned Japanese Americans, right? But did not intern Italian Americans or German Americans. Did you ever think about that, right? Let's think about people of African descent. And actually, when 2 years ago, a lot of people were afraid that we were going to start interning people who looked Muslim or Middle Eastern, North African, or the like. Never did we understand that we would be jailing children at our border. We need to be aware of all this going on. All of us need to feel connected to those children right now. You know the thing, I can't even tell you who said it or how it was, but first they came for that group and I didn't care, it wasn't me, and then finally they came for me and there was no one left to care. Okay, this is just a heads up. I'm not trying to be political, I'm trying to just be real right here. But for people of African descent, the initial historical injustice was the kidnapping of West African people, our importation across the Atlantic with tremendous loss of life in the Middle Passage, and then for the survivors and their progeny for generations, what I describe as the coerced usury of our unpaid labor for centuries to build this country. But when I start talking like that, people were like, oh, Dr. Jones, there you go, talking about slavery. Dr. Jones, we all recognize that slavery was an unfortunate chapter in our nation's history. But Dr. Jones, the enslaved people were emancipated by 1865. And we're in 2019. That makes that 159 years ago. So Dr. Jones, all else being equal, don't you think the impacts of slavery would have washed out by now? The key phrase is in their question, all else being equal. All else hasn't been equal since 1865. All else still is not equal today. And there are what I describe as present-day contemporary structural factors that are perpetuating that and each of these other initial historical injustices. And these contemporary structural factors are part and parcel of institutionalized racism. So when you ask me, am I talking about racism or am I talking about social class? My response is that institutionalized racism explains why we even see an association between social class and race in this country. That is a very important aha. I just want to take a moment to say one more thing, though. Sometimes people say, Dr. Jones, you are so on this racism and anti-racism thing, you don't care about poor white people, do you? And I was like, oh, that is not true. I care deeply about poor white people, poor Hispanic Latino people, poor black people, poor Asian people, poor Indian people, poor every people. And we need very vigorous anti-poverty strategies. But even if we boiled all of those anti-poverty strategies into this thing and I went and eliminated poverty across this land today, even if I went further than eliminating poverty, even if I eliminated income inequality, flattened the whole thing out, if I did that without addressing the background structures, policies, practices, norms, and values, the mechanisms of institutionalized racism, which are deeply embedded in the fabric of this nation and were put in place to differentially shunt different populations to different possibilities, even if I flattened the whole thing out today, if I did that without addressing institutionalized racism, then in one generation, in 20 years, we would start to see a stratification by race in terms of income again. This is not an either or anti-poverty and anti-racism. This is a both and. Yeah. Before I leave this slide, one more thing I want to say, that institutionalized racism can be through acts of doing, acts of commission, as well as acts of not doing, acts of omission, and very, very often institutionalized racism shows up as inaction, lack of action in the face of need. The second level of racism, personally mediated racism, I define as differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. So this is what most people think of when they hear the word racism. Somebody did something to somebody. It includes the different idea, the prejudice, and the different action, the discrimination. And we've had lots of examples of that in the general national media and even here, you know, napping while black, right, here at Yale, right? So anyway, examples. Police brutality. Police officers interpreting the cell phone of a young man in his own backyard as a gun and shooting him however many times in the back and killing him. Every time that we hear these stories, I used to do a litany of names in the same way of remembrance, Ashe, and I cannot keep all the names, even of people who have come to national attention in the past few years. And those are the